heard before, he just spoke of the etiology part. Now he's coming to the most important thing which we all face. I think so is mainly with the parents, at the times there are the labs who give us some packages, and then the patients come to us with a big book, and then when we start reading it, I think so we are confused. I think so to change that confusion and what, when and how, he's the man over here for us. Over to Dr. Neeraj.
Thank you, sir, for the nice introduction. And first of all, I would like to thank the organizers. Special thanks to Dr. Nemi, Dr. Krishna Mohan for inviting me here, Dr. Soli, and all the organizing team. And I'm really glad to see. And in fact, each and every time when I come to this part of the country, the house is always full since the morning up till the evening. And it is so much interactive. And I love this part of the country much more than my own part, because the people are so interactive here and they are so much into discussion. So I really like that. So thank you for doing that. And thank you for inviting me here. So as sir was mentioning about the topic, which is investigating allergy, what, when and how. So once again, we will be trying to have more interaction with you. So let's see, the question is that why we should do allergy testing. If we just see the perspective in a way that, are these allergies something which are new? Allergy is something which the allergy hoopla, I will say, which has been created by few crazy people, including me, for past few years, right? What we are doing, why we are doing that? Is it so much needed? Is it so much hyped? It is something, a new disease which has now come up after COVID, or something which has happened now? Or was it previously there, but it was probably, we have never recognized it? So there are certain questions which you need to ask from ourselves. So allergy is something which is considered to be an ancient old disease, and in fact it has been considered to be part and parcel of human civilization. As soon as the humans started civilizing, or the human population started civilizing, then at that particular time the allergic diseases started coming. If you want to make it as simple as that, so as simple as that is that if one particular individual, human individual, is reacting abnormally, or the immune system is reacting abnormally to another thing, that another thing could be anything in this world, then at that particular time, that symptom which is produced is called as allergy. So to me, practically, each single individual on this earth is allergic to probably one or the other thing. Universally, every husband is allergic to wife and vice versa. So this is also happening, and then there are so many other things which are happening. Now, the question is that let's talk today in the modern medicine, when we are talking about allergy testing, and sir mentioned about a bunch of papers which the people carry with different sort of allergy testing. So do we really need allergy testing, or it is just a clinical diagnosis? So let's see what the evidence is. So this is the table from the GINA. GINA, you know that this is considered to be like a Bible guideline for management of asthma. Okay, so this is considered to be a modified asthma predictive index. What it means? It means that if a patient, a mother comes to us somewhere around with a child of 3-4 years of age, you put the paper that, okay, your child is suffering from asthma, it's a childhood asthma. The next question she will ask you, okay doctor, but whether my child will improve, he will come out of this disease, or he will stay asthmatic, it will turn into adult asthma. So this is called as asthma predictive index, or modified asthma predictive index. There are certain criteria in this, major criteria and minor criteria. Among the major criteria, if you just see carefully, allergic sensitization to at least one arrow allergen. Among the minor criteria, you see allergic sensitization to milk, egg or peanut. What it means? That means if you need to predict that whether this particular person will outgrow from his allergic problem, from his somatic problem or not, then at that time you need to do some sort of allergy testing. And you need to find that whether this particular person is sensitized or not sensitized. Then only you will be able to satisfy this criteria, and you will be able to predict somewhat that whether this particular child is come out of it or will not come out of it. So definitely allergy testing is having a predictive role, that you can definitely predict that what is likely ahead in another few years' time. Now this is another graph which is showing, in which if you just see on the bottom, there's the x-axis, there are time in the days. They all are the children who are suffering from asthma, and they are taking their asthma management from all the pediatricians or physicians, those who are taking care of them. So if you just see the number of asthma exacerbations for which they required rescue medication. So the blue line is of those children who were only isolated on pharmacotherapy, whereas orange line is of those children who were on pharmacotherapy plus allergen immunotherapy. What it means? That if they were able to identify, the physician was able to identify the correct allergen timely, by doing certain testing, matching it with the symptoms, and started the correct treatment, appropriate treatment at the right time, which is probably allergy and immunotherapy. Then at that time, the number of exacerbations were lesser as compared to only pharmacotherapy. It translates to that allergy testing is having a therapeutic ability. So both predictive ability as well as therapeutic ability. That is the reason that we need to do allergy testing. Now the question is, okay, we understand that allergy testing should be done. Which common allergens we need to test? So the most common allergen is dust mite. What is this dust mite? Anybody can tell me in the house? House dust mite, I think my previous colleagues have also mentioned about house dust mite. What is this house dust mite? Anybody? Please, I'm sure that 50% of you already know about this house dust mite. Anyone, please? Anyone, please come out. What is house dust mite? Have you heard this name? Okay, so house dust mite is basically a misnomer. It is actually a house mite. It's not related to dust, it is a house mite. It is a small insect. It's a very tiny insect. If you just imagine the diameter of the human hair, which is approximately 150 microns. The human hair diameter is 50 microns, 50, and the house dust mite size is around 150 micron. So it is nearly 2 to 3 times the size of the diameter of human hair. You cannot see it with the naked eye. It is very small, very tiny. It requires certain conditions to thrive: humidity and heat. So in our country, the humidity and heat is ample, and especially in this part of the country, the humidity is very high. So in the coastal areas, the humidity is very high. So it is considered that these are the two conditions which are required for the growth of the dust mite. So dust mite is very happy in a humid area which is having more than 50% or 55% humidity level in the atmosphere. And the temperature, which is the ambient temperature, somewhere around 30-35 degrees Celsius, it is very happy with that. So in India, we are having ample conditions for dust mite survival. Where dust mite is surviving? Dust mite is there in the mattresses, in the pillows, in the carpets, curtains, everywhere. So this dust mite is born for only one purpose. The purpose is eating. It is a voracious eater. So dust mite is eating. And what is it eating? It is eating the human hair, danders, epithelial cells, which are falling over the, you can say, like the surfaces wherever we are lying down, sleeping, lying down. So all these things. So dust mite eats them, and then as soon as it eats, it produces certain poop. It's a fecal material. The fecal material is of the size of PM10 particle. PM10 particle means any particle size which is in between 2.5 to 10 microns. Now this PM10 particle, when it is getting inhaled with the aerosol, with the aerosolization, it goes in the nose, and you are very well aware that PM10 particles are majority responsible for allergic rhinitis. So PM10 particle, or the house dust mite poop material, is mainly responsible for this allergic rhinitis. When a person is going for sleep in the night, somewhere around 10 o'clock time, at that time mattress is there, pillows are there, blankets are there, everything is there, carpets, curtains, everything is there. So that is the ideal environment for, you can say, like hundreds of thousands of and lakhs of dust mites which are there, and then the person is inhaling them. So the more symptoms come in the night, more symptoms of asthma exacerbation, more symptoms of, you can say, like rhinitis exacerbations, sneezing, and all those things. They come in the late night, early morning hours, early morning sneezing. These all things happen. More common symptoms are there in the post-monsoon season, or in this part like March or April time of the season. These can happen, but yes, they can be perennial also. So these are the dust mite which are more common. So this is one study from South India which is saying that dust mite is more common, but there are other allergens. Could be certain pollens, could be grass pollen, tree pollen, depending upon which weather they are there. Insects. Among the insect, cockroach is the most common. Anybody has seen cockroach in the last 1 month at your home? No cockroaches at your home? No. So one person has seen. So it is said that cockroach is considered to be that organism which lies everywhere. You cannot just kill cockroach, okay? So cockroaches usually lie inside the drainage system of the houses. Right now the drainage system underground, we can't see that. So we feel that the power of attorney of the house is in our name, but cockroaches feel that it is in their name, because we stay awake in the daytime and they stay awake in the night time. So the working hours, the shifts are different. We are working in a shift duty. And that is why we feel that we are owner of this house, they feel they are owner of this house. Whenever our children or we are eating somewhere or other, we are spilling the food here and there on the sofas and everywhere. At the night time, the cockroaches come with the 2 antennas, they are searching for the food, and then they just go there, eat, and then they produce all that allergenic material. Okay? So it is considered that even with the Iran and America war, when the nuclear bomb is probably the threat, so the cockroach will still survive if the nuclear bomb will come. Okay, rest everything will go away, but cockroach will survive. So cockroach is that type of organism which is very resistant, and it will be available everywhere. Okay, even if you have seen or not seen. Now, if you see a cockroach and you hit the cockroach with probably something, then at that particular time the allergenic material will spread in the environment like anything, like a splash. So you are actually increasing the allergenicity. Okay, so that is even more harmful. So cockroach is considered to be the most important, most common insect among the sensitizing agent, and then there are certain fungi also. This is study from our center from North India. Once again, dust mite and cockroach, these are the two most common culprit for the asthma and rhinitis. And so these are the things which we know that, okay, which one to detect and what to detect. Now the question is how to detect. That comes the question of allergy testing. So the first most common, most effective way of doing allergy testing is the clinical history. Allergy is 90%, 95% of the time spending time with the patient in the clinic, somewhere around 40 minutes, 45 minutes with a good history. You need to really dig deep into the history, that what are the symptoms, what are the chronological order of the symptom. A patient who came to you, 5-year-old, with the symptoms of asthma, you need to really ask what happened in infancy, whether the child has undergone through eczema period, atopic dermatitis period or not. That will give an important clue that whether the child has traveled through the atopic march or not. That means food allergy first, eczema first, it got resolved by 2 or 3 years of age, and now the asthma started. When the onset of symptoms were there, what are the housing conditions? Which type of house he is living, that means with the humidity level, and whether the ventilation, sunlight exposure, whether there are certain plants in the house, what is the daily living of the child, how the child is going to the school, whether the child is going to the school with the auto rickshaw, with cars with the windows rolled up, with the cars with the windows rolled down, or the AC buses. So different type of exposures, different type of routes, and different type of allergen exposures will be there. So we need to take all these minor details in the things, whether there is any incense stick burning which is happening, dhoop battis, agarbatti, somebody is smoking inside the house, somebody is smoking outside the house. So which particular type of food items the child is consuming, family is consuming, even if the child is not consuming, where the child is going. So all these things need to be taken into account with a very deliberate history, and then we come to know that, okay, probably this seems to be allergy or not allergy. If it is allergy, then this seems to be the culprit agent, and we try to narrow down our agents, our culprit allergens, to less than 10. Somewhere around 6 to 8 are sufficient enough by a good history. And once we have decided with the good history, then we choose a relevant testing. So before we go to the relevant testing, I will discuss one slide which is type 1 hypersensitivity, and that will actually explain all the sort of testing. So we understand the initial contact with the allergen will happen. So it goes and connects to the antigen presenting cell or the allergen presenting cell on the T cells, and which ultimately stimulate by the Th2 pathway. It's a Th2 polarization which happen, and with the Th2 pathway, the B cells are stimulated, plasma cells are produced, IgE is produced. So this IgE, which is released in the circulation, now this is roaming around. So if the allergen is entering through the skin, allergen is entering through the nose, or it is entering through the bronchial mucosa, any of the route allergen is entering, then at that particular time the IgE is produced. This IgE is going in the systemic circulation, and this IgE is having a very peculiar capability that it cannot stay in the circulation in the free form majority. So it goes and attaches to the mast cells and the basophils. So the bound IgE is more commonly found as compared to free IgE. So free IgE, and simultaneously you will see that there are certain mast cells which are having attached IgE molecule, which is called as the bound IgE. Now these mast cells which are actually having bound IgE attached to their surface, they will roam around in the circulation here and there, and after that, on a re-exposure of allergen, when it comes, then it will get attached to the bound IgE, and ultimately the mast cell will get the signal, mast cell will burst, and then after bursting, the histamine and the other chemical mediators are released, and the clinical symptoms will happen. Now the patient is presenting to us with this particular time. At this stage where the clinical symptoms are there, when the patient is presenting to us, we want to catch him at least at this point where the IgE is released, or at this point where the IgE is attached to the mast cell. That means there are two types of IgE, you can say like areas, we can catch hold of that particular type of reaction. One is the free IgE, if you just see this free IgE, and another is the bound IgE, which you just see that which is there on the mast cell. If you are doing any test which is detecting this free IgE, so this is basically the blood test, or it is the basis of the in vitro testing. So any blood test when you are doing, then at that particular time you are actually detecting this free IgE molecule. Whereas if you are re-challenging the patient with this particular allergen again, so it becomes the in vivo testing. So that could be a skin prick test, that could be an intradermal testing, or that could be a challenge test. So in vivo testing inside the patient if you are doing, so that means you are re-challenging the patient with the allergen, so you are detecting the bound IgE. Okay, so this is the difference between free IgE and bound IgE. This is the difference between in vitro and in vivo testing. Now, when the free IgE molecule is released and you are able to detect free IgE, that means your blood test is positive. But it is still possible that that particular free IgE might not have attached to the bound IgE. It is still possible that the re-exposure of allergen might not have attached to the bound IgE and ultimately the reaction might not happen. That means a positive blood test, a positive detection of free IgE molecule does not directly translate into clinical symptoms. What I want to say that if a patient who is coming to you with a positive allergy test report, the blood allergy test report, still he might be asymptomatic because he is doing a lot of testing because of panel system, because of the insurance issues. So they are just getting the testing done, but it might not be relevant to the patient. It is possible. In a particular report, there are out of 100 allergens, there could be only 40 allergens which are positive, and out of the 40, only 2 might be relevant clinically, rest 38 are false positive, so which is very well positive. So this free IgE detection is called as more sensitive test. So blood testing is more sensitive. Blood testing is more sensitive, so it is having a better negative predictive value. The things which are more sensitive will have a better negative predictive value, but positive thing we really don't know. We need to know with the bound IgE, that means the skin prick test. So you do with the skin prick test, and then if it comes out to be positive, then at that particular time, yes, it is more near the truth, not equal to truth, but more near the truth, so it is more specific. I will put the context in such a manner, like for an example, we all are sitting here, and if I just want to count that how many people are wearing white shirt here, probably 6 people are wearing white shirt here, which is a free IgE molecule. If I just say that how many people are wearing white shirt and sitting side by side together, like if you just see 2 IgE molecules sitting side by side together, and then an allergen is coming and binding here. If it is only a single IgE molecule, it will not bind. So it requires a double IgE molecule which are sitting on the mast cell, and then only it will be able to bind. So I have added one more condition, that 2 people wearing the white shirt sitting side by side together increases the specificity. The skin prick test is always much more better as compared to the blood allergy testing. Am I clear here? So blood tests are more sensitive, better negative predictive value. Whatsoever is negative in the report, you can say to the patient, don't worry, you can eat this. But whatsoever is positive, I don't know whether you are allergic to it or not allergic to it, I need to see it. Okay? Whereas the skin prick test is much more one stage advanced test as compared to the blood test. So what is skin prick test? So this is the skin layer which are divided into like a epidermis, dermis, hypodermis muscle layer, among which if you just see carefully, in the epidermis there are no blood vessels, there are no pain fibers. What we are doing is that we are just putting a allergen drop, minuscule drop, and the lancet is coming. Yes, so lancet is coming and it is distributing or delivering this allergen drop into the epidermal layer only. And then thereafter the lancet is removed. And now as per the concentration gradient, now this goes down, this diffuses down, and this goes to the, you can say like the mast cell, and the bound IgE it get attached, and ultimately the histamine and other things are released. What I want to say, a correctly done test, a skin prick test, is a bloodless and a painless test because it is an epidermal test. You are not entering in the dermis. The blood vessels and the pain fibers are in the dermis. They are not in the epidermis. So it is a bloodless, painless test. It is a very, you can say like useful technique which can be done. But there are certain conditions in which you cannot really perform skin prick test. That could be like a widespread eczema, you require a healthy skin, then only you can perform skin prick test. Soon after anaphylaxis, if a patient who presents to you with some history of anaphylaxis at that particular time, all the histamine and other chemical mediators are likely released with the bursting of the mast cell, it will require nearly 4 weeks time to replenish themselves. And then only you can perform a skin prick test. If the patient is on antihistamine, naturally because this test is based upon histamine release. So if a patient is already on antihistamine, you need to stop antihistamine. If a patient is on oral steroids for more than 10 days, or if a patient is on anti-IgE molecule like omalizumab. For omalizumab, you need to stop omalizumab 6 months. and then only you can do skin prick testing. And then many a times it becomes difficult, like whenever you are pricking them 4 times, 6 times, 8 times, so the fear of prick might make them anxious, children as well as their parents. So many a times you cannot do that. So at that particular time you need to rely on in vitro test, which is the blood test. Okay, so this is the in vitro test. Now among the in vitro test, the most favorite test is called as total IG. Total IG is something like that a patient comes to, I think this, let's take the example of Little Flower Hospital. So a patient comes to the gate of the Little Flower Hospital and asks the guard that, okay, I need to meet a doctor. Now this guard doesn't know where to send. He has just mentioned I need to see a doctor. He can send it to any doctor. Could be a pediatrician, gynecologist, surgeon, ENT, biochemist, anywhere. Everybody is a doctor. Very non-specific information, very non-specific action. Same way, total IG. Total IG can be increased in so many things. It can be increased with some infectious disorders, could be atopic disorders, could be immunodeficiencies, could be various other disorders, COVID, post-COVID, HIV, post-HIV. So total IG is a very non-specific test. Many a times we get a referral from a patient. Why you have come? Sir, I have done this total IG because it was included in the panel, and the total IG previously was 400, then it has become 1100, now it has become 1800. Then I started taking some anti-IG therapies, and then it has now become 900. What is your problem? My problem is total IG. So he is not having any clinical features. No problem. It is in the panel. One report came, he started chasing that report, and ultimately he has come to you. So total IG is not the test for allergy testing, my friends. Just forget about this. Okay, total IG अब हमें नहीं करना. We will not do total IG from here onward. Right? Total IG is indicated in allergy practice only in very selected conditions. One, if you really need to treat a patient with anti-IG molecule like omalizumab, especially ABP, at that time you need to calculate the dose of omalizumab, you require total IG. Or sometimes you want to see hyper IG syndrome, in which total IG is somewhere in 4 figures or 5 figures. That could be 10,000, 50,000, 1 lakh, something like that. Otherwise, normally total IG is not required for any other allergic diagnosis or management. So if total IG is not required, now the same patient who came to the guard at Little Flower Hospital gate says that guard sir, I need to show my child, 5-year-old child. Now guard has got a better information. So he will send this particular child to the pediatric department. Better information, specific result. So this is called a specific IG. That means you need to tell the laboratory, I need to test dust mite allergy, I need to test milk allergy, I need to test peanut allergy. Then they will test against that IG only. They will not do total IG. They will do dust mite specific IG, milk specific IG, that way. So this is called a specific IG. So there are several techniques. So whenever a piece of paper comes to you with the report, you first need to see that which technique it has been done. If it is written FIA, which is fluorescent enzyme immunoassay, or immunocap, that is the only standard technique. Rest others are non-standard techniques. So FIA is the only standard technique. So please see whether it is written FIA or it is written immunocap. They both are same. What it is doing, it uses a fluorescent labeled enzyme. If I just go to the diagram, so what is happening? So the allergen is there, which is covalently bound on a solid surface. So these black triangles which you see here, these are the allergens which are bound on a solid surface. And then in the machine, when you are putting or pouring the serum of the patient, if the serum is having the IG antibodies, then at that time these IG antibodies will attach to these bound allergens here, and then thereafter an anti-IG molecule which is attached with the fluorescent dye. So this will get bind to the IG, and ultimately with the intensity of the color of the fluorescence, you will come to know that okay, this particular person is having this much amount of IG antibodies which are available. Right? So this is basically the technique, which is FIA technique, which is considered to be the gold standard. Now, what is immunocap? So immunocap is basically like a brand name. You consider like a brand name which is given by a company called Thermo Fisher Scientific. So technique is FIA. Immunocap is the brand name which is patented or a proprietary name which is used by Thermo Fisher Scientific. Both are same. They are interchangeable. Don't worry that they are same. Right? Now this is considered to be gold standard testing for in vitro testing. It is having a high sensitivity, using a solid phase design. It is standardized and it is quantitative. What it means quantitative? That means, for an example, a patient comes to you, you have diagnosed something, the levels are let's say 50. You have advised him probably avoidance or whatsoever XYZ measures, and 6 months later, 1 year later, now the level became 5. or the level became 1. So this is having value. From 50 it has dropped to 5, it has dropped to 1. So it is having a quantitative value, which is important. But the problem is cost. Each and every single allergen which is tested will cost approximately 1000 rupees. So suppose if you are testing 10 allergens, then at that time 10,000 rupees. If you are doing a panel of, let's say, 60 allergens, so you can just imagine that how much costly it will become. Okay, so the disadvantage is a cost. Now in India, majority of the people are pocket payer, out of pocket payers, and it becomes really difficult. So can we do something? Yes. Then at that time we can probably work with a lesser reliable technique. So which is the lesser reliable technique, which are called as the semi-quantitative methods. These are the semi-quantitative methods are based upon the method, like for an example, during the MBBS days, everybody has done that Eurostick method. This for detecting the proteins, nephrotic syndrome patients. So urine sample is there in the test tube and you are just dipping the stick. So on that the glucose is also detected, ketone is also detected, protein is also detected. Same way, on a one particular paper strip, if you are just attaching several allergens together, right, and you do it with a dipstick method, then this becomes, you can say, like a very cost effective technique, and in which 3,000, 4,000, 5,000 rupees you can actually detect 40 allergens, 50 allergens, 60 allergens. But the problem is that these can be reported in grading. So the grades will be there, grade 1, grade 2, grade 3, grade 4, grade 5, and this is a semi-quantitative method. You cannot really rely on that okay, earlier the value was 50, now it is 5. You really don't know whether 50 is correct or 5 is correct. They both are same, because this is reported in grading. It does not have a quantitative value. This is importance here, right? So these are the differences between quantitative and semi-quantitative test. Quantitative, I told you, immunocap, which is the gold standard. Semi-quantitative, sometimes we have to go on semi-quantitative because of the cost issues. So these are the differences which I have just mentioned you. Now it is very convenient for the patient. One prick, whatsoever number of allergens you want to detect, you can detect any condition of the skin. Soon after anaphylaxis, patient on antihistaminic, you can actually do it. But the problem is, the most important problem is the cost. And second problem is, I told you, it is in vitro testing. It is very sensitive, so it can give you false positive results. I told you earlier, it can give you false positive results. Okay, so each technique I have told you different pros and cons for that. So in vitro test and in vivo test. Is it clear till now? Okay. Now you can probably ask me that total IgE you have told not to do. I am not an allergy specialist. To start with, I don't know what allergen to test. So can I do something in my OPD to detect or to say that okay, this particular patient needs to go to the allergy specialist, or this particular patient need not to go to the allergy specialist? So yes. What this company people have done, they have combined few common allergens, 8-10 allergens together to make it cost effective, which is called as Phadia Top. So Phadia Top is basically immunocap only, but Phadia Top is a platform. And this platform, what they have done is that in that Phadia Top, they have given us a screening test. So there are two types of Phadia Top test. One is called as less than 5 years, another is more than 5 years. Less than 5 years is also called as infant or child. More than 5 years is called as adult. So even if you don't remember, you just write Phadia Top screening and you send it to the laboratory. Laboratory people have been taught, any child which is less than 5 years, do this one, more than 5 years, do that one. They will automatically do it for you. Okay, what it means? If you just see less than 5 years, then at that time they have included one species of dust mite. This is one species of dust mite, Dermatophagoides pteronoecius. This is one species. Then the common animal dander, cat and dog, few pollens, egg, milk, peanut and shrimp. And we understand that food allergies are more common in children. That is why they have included here 4 common food items, right? These are there in the Phadia Top infant. Whereas in the adult, it is more than 5 years, so no food is included. So 2 species of dust mite, horse is also included as animal dander, 1 pollen added, and 1 fungus is there. So these are the common things. Now this test costs somewhere around 1,000 rupees, 1,100 rupees. Suppose if this test is negative, you are 95% confident that all these allergens are negative in this patient. Suppose if this test is positive, there are 95% chances that 1 or 2 among these will be positive. Then you need to detect individually. So a second step testing you need to do. That second step testing you can do either blood test or skin test depending upon you. So this is more like a screening test. Am I clear here? So instead of total IgE, the Phadia Top becomes a screening test for us rather than total IgE. So this I have told you about that. So individual allergens or specific panels you can always make. So you can always ask your colleague, the pharma colleague, and then they can tell you that which particular allergens you can bundle them up in any permutation combination that you can do. So I will just quickly discuss few cases and thereafter we will wind up. So first case, baby of Razia, 9-month-old male child, presented to us with eczema over face and scalp since 6 months of age. The parents have told that the child was exclusively breastfed up till 5 months, and then the child was started on formula milk. And the symptoms, especially this atopic dermatitis or eczema, started somewhere around 6 months of age. On examination, the skin is very dry, and the lesions are present on the extensor aspects of both elbows, which are there. So it's a typical example of atopic dermatitis in infancy, which started few days after starting formula milk. No other food item has been started. Okay, so it seems that this might be having a milk protein allergy. Okay, so we tested this child with and found to be having IG mediated milk protein allergy. These were the test results. Skin prick test was positive, specific IG was also positive. We were advised for milk and dairy avoidance and extensively hydrolyzed milk formula prescribed. So doctor is very happy, parents are very happy. Parents started walking away, and the moment she was about to go out of the gate, she turned back. She asked, "Doctor, can I give any other form of milk? That could be ghee, that could be some sort of baked form of milk, could be any other different form of milk. You told that my child is having milk allergy. Can I do something different with the raw milk? Can I do something different?" So what will be your answer? The child is demonstrated to be having milk protein allergy. Can you answer now this question? He cannot drink milk, but can he take some product of milk like biscuit or probably some bread or some cake or something like that? What is your answer? Anyone? So now you need to break down the milk protein into different components, and you need to go into molecular allergy or molecular allergology, in which what you can do is that, so these are the several milk components, protein components. So it's not only one milk protein. The one milk protein is grossly divided into heat resistant and heat labile group. Among the heat resistant, all the casein family, alpha casein, beta casein, kappa, and all those casein family. Among the heat labile group, it is the lactalbumin families which are there. So the clinical significance is that if I detect the component and I come to know that okay, this particular child is actually having the heat labile component rather than the resistant one, I can advise him that okay, you need to boil the milk at least this much time, this much temperature, and thereafter you can probably give it, because the allergenic potential will reduce. So this is called as component testing. We did the component testing, and fortunately the heat resistant, which is casein, came out to be negative, and the heat labile came out to be positive. So this particular child can actually take baked milk product, which are these. But if the results would have been vice versa, that means the casein would be positive, then at that time nothing can be done. The other is important thing is that the heat resistant one will take longer time to get resolved as compared to the heat labile one. So this is the utility of allergy testing. Okay, these are the components in the egg protein. One is heat resistant, one is the heat protein labile. So the message from the first case is that knowledge about component proteins is important. It can actually help you in dietary advice, and simultaneously it can help in predicting the resolution. Second case, 3-year-old child presented with urticaria rashes and breathing difficulty. What is happening here? 3-year-old child, urticaria and breathing difficulty. Notice some itchy rashes earlier after peanut and egg intake. Unable to correlate with any food item. What is happening? Anyone please? Urticaria plus breathing difficulty. Two systems involved. There is some history of food allergy. Dog is there at home. Previous sibling asthma. What is happening? This is anaphylaxis. You must not miss anaphylaxis. This is important. What is anaphylaxis? Anaphylaxis is something in which there are some skin manifestations, plus one of them could be respiratory compromise, hypotension, or persistent GI symptoms. Or even a single symptom with a known allergen exposure is sufficient enough to call as anaphylaxis if this symptom is life-threatening. So this is important. Anyway, coming back to the case, the child was managed with ER with injection epinephrine, discharged on steroids, antihistamine. 1 week later, during a scheduled OPD visit, now parents want to know the cause. What happened, doctor? Is this thing going to repeat with my child? What can I do? So, what you will do now? 1 week later, this is the patient with you. Now you are more learned than me about allergy testing. What will be your advice here? I think the mic voice is not going behind because nobody is responding. There is some problem with the mic. No? Oh, it has started going now. Yes, please. Somebody was saying? Component resolved diagnostic. Okay, very nice answer. So what is your aim? What you want to see here? And what allergen you want to target? Sorry, can somebody give mic to it? Yes, sir.
Peanut.
So peanut, if you want to see, so peanut, that means specific IG you want to see. So why you want to directly jump to component? So first you will see specific IG, correct na?
Yeah.
Either specific IG or SPT, correct?
It was skin prick test.
You want to do skin prick test?
Yeah.
I agree with him and I disagree with him. So who agrees and who disagrees? Who will support your friend? Support? Disagree?
Support.
He is supporting. I am disagreeing now. So
Heavy skin prick test for food allergens, it may not be possible.
no, you can do it.
Yeah.
I am disagreeing with the skin prick test in this child. Anybody supports me?
Anaphylaxis is there.
7 days only anaphylaxis.
Yeah.
I told you 4 weeks you have to wait.
Yeah.
You have to wait for 4 weeks. 7 days history. So you cannot do skin prick right now. You have to wait for 4 weeks. And what you can do is right now, only blood testing, in vitro testing. Okay? So in vitro testing you would like to plan. Which allergens you would like to plan for in vitro testing? This was the history. Which allergens you would like to choose? Peanut you told. Well taken. Anything else?
Egg.
Egg. Good.
Then,
Anything else?
the house dust, house mite. Because,
House dust mite causing anaphylaxis. Are you sure?
no, because
As a first choice, you want to keep house dust mite causing anaphylaxis? Want to test house dust mite now?
no, not.
Not. Taken back. So peanut,
Peanut and egg.
egg. Anything else?
Dog.
Let's see. Let's see what they have done. So SPT, you cannot do it. Very good. Specific IgE will be done. So they did peanut and egg. Well taken. Thank you, sir. So peanut came out to be positive, grossly positive, 36.6 in this child. Peanut seems to be the culprit. He has taken peanut, went into anaphylaxis. Peanut specific IgE is very high. Normal value 0.1. Cutoff is there. 36 is very high. Clear. It's a peanut allergy. Now the question is that you told them that okay, you need to avoid dietary peanut. Will you like to advise something else extra? Peanut, avoid. Anything else? Can you do? Anything else? Can you do? Component testing. Once again. So in the component testing, there are certain components of peanut which are, you can say, like a higher risk of major anaphylaxis again and again. And there are certain components which are milder, which are less likely to produce another episode of anaphylaxis. Which are these components? So the components which are mentioned in yellow color, these are safer, whereas the components which are mentioned in red color, they are at higher risk. So this particular child will go with EpiPen at home. So if you just see report of this particular child, he is allergic to the red one, 2 and 6. So 2 and 6 are the red one, the top one category. He will go with EpiPen. So he is at a higher risk. Okay, and this particular child also needs peanut oral immunotherapy, which is not available right now, but yes, peanut oral immunotherapy is also needed. So permanent cure can be done, but this is actually not permanent cure. Peanut oral immunotherapy is also like a sustained unresponsiveness, or you are just able to provide the, you can say like the unexplained accidental exposure, that's all. So message from case 2 that you can actually predict the severity of subsequent reaction by component proteins and help in guiding the EpiPen prescriptions timely. Last case, case 3, 10-year-old Ria, diagnosed with the case of asthma and allergic rhinitis, now controlled with ICS, LABA and inhaled nasal corticosteroid, undergoes allergy profile testing. This is the profile testing. Dust mite 5 into 5, cockroach 3 into 3, specific IgE, dust mite 12 positive, cockroach positive, shrimp positive, all 3 positive. They are pure vegetarian. Okay. So what is your interpretation? How will you interpret? Anyone? Dust mite positive, cockroach positive, shrimp positive. Pure vegetarian family. Never taken shrimp. Anyone? Once again, you need to see that why the shrimp came positive. So whenever you are testing, you should be having a question before that. What is your question here? Shrimp is positive, but the patient is vegetarian. So why shrimp came positive? is shrimp is having any component which is cross-reacting with the cockroach and dust mite, and that is why it is coming positive. So your question is there, and the component, the cross-reactive component here is tropomycin. Tropomycin is one component which is shared with the dust mite, cockroach and shrimp, and that is why all the tests came positive, but the patient was not having or there is no history of shrimp intake, right? So this patient seems to be allergic or sensitized to dust mite and cockroach, and then thereafter you will go further. So now the question is, when we are talking about so much about molecular diagnosis and all those things, so are we going to replace that with the conventional allergy testing with the skin prick test or the specific IG? So the answer is no. Because if a 5-year-old child came to a pediatrician, so pediatrician can practically manage each and every pediatric condition. He need not to have each and every time their super specialist friend could be pediatric neurologist or nephrologist. Only selected conditions. That means refractory conditions. Then only you require your super specialist friend, otherwise not. So you definitely need to understand first MBBS, then MD, and then only you will think about DM. So same way, allergy testing. First is your crude allergy testing. Then you have a question. If there is a question, then only you start doing component testing, otherwise not. If you directly do component testing without having a question, you will be inviting more troubles, because the component testing will give you so many positives, and then you will be in a bigger trouble that what to do and what to answer to the patients now. So the concluding remarks, which allergen should be tested for? So for respiratory allergy, especially dust mite, cockroach, animal danders, and then depending upon the exposure, suspected food items and pollens. Which test? It all depends upon the history and geography, and skin prick versus specific IG. When there is a recurrent or the persistent symptom. If somebody who is just having, you can say like needing a tablet cetirizine twice in a year, you need not to test him, but you are going to offer him after even testing. So you need to first ask a question that if I can offer a relevant remedy to the patient or not, and then only do the testing. And allergen avoidance and immunotherapy is the thing. So these are the things. If anybody is interested in joining our initiative, which is sleep, asthma and allergy, we have combined everything together. So you can just scan the barcode and you can join us. It is complimentary, so no charges for now, but soon we are going to implement the charges. So thank you so much.
Thank you so much, Dr. Neeraj, for such an excellent session. So now we are moving on to the inaugural session. Before that, if you have some questions, 1 or 2 questions can be taken up.
Yes, sir. Sir, please use mic.